Good evening. Welcome. Thank you for joining our live event tonight. Our topic is going to be gynecologic concerns in girls and young women with anorectal malformations.
We're hosting tonight's event because we've heard that a lot of families have questions and concerns about their girls' gynecologic issues.
We're excited to be here tonight. My name is Dr. Lesley Breech. I'm a pediatric and adolescent gynecologist here at Cincinnati Children's Hospital. I've been working here for about 10 years. I'm very lucky because I am working in a group that provides reconstruction and pelvic reconstruction for girls and young women with a variety of congenital anomalies, including anorectal malformations.
And I'm Debbie Morse. I've been a nurse for almost 38 years. 36 of those have been here at Children's. For the past 7 years, I've had the opportunity to work with Dr. Breech, and I'm responsible for managing the care of our patients with more complex gynecologic concerns, including girls with anorectal malformations.
I've been very lucky to work with Debbie over the past 7 years, and I think she's just a reflection of one of the members of our team. We're very lucky here at Cincinnati Children's to have an interdisciplinary team that provides care for girls and young women with complex genital anatomy, girls who may require reconstructive surgery, including girls with anorectal malformations. I have found that in my interactions with patients and families, it's been valuable to them in the way that we work together as a team. We are the gynecology team, and we work closely with the urology team, the surgeons, as well as gastroenterologists, social workers, and a very strong nursing staff.
We're very excited that you're joining us here tonight, and you can start submitting your questions now. It'll help us out if you only enter your question once. We're going to be here for an hour, and we will try our best to get to every question. So, Dr. Breech, the first writer writes in that her daughter has 2 half uteruses, 2 half cervices, and she wants to know about her chance of conception.
Well, that's a very interesting question. In patients who have reproductive anatomy that may not be expected, most girls and young women will have a single uterus, and I usually call the uterus the house, with a single front door called the cervix, with a single walkway leading up to the front door. Now, in patients who have complex genital anomalies, they could actually have 2 half uteruses, or almost like a duplex, each with their own front door, each having a cervix or half cervix, and then often having their own walkway leading up to the front door. I actually included a diagram that we might turn to now that you could see. So I actually think that this is probably what the person asking the question is describing. Someone who has sort of 2 half uteruses, 2 cervices, or each of these half uteruses having their own front door, and probably initially having 2 hemivaginas, or each having their own walkway leading up. In most reconstruction, the vaginas would be unified, so there's a single vagina. And patients then menstruate from each cervix or through each front door and out the same walkway. And therefore, most patients will have normal menstruation, both sides occurring at the same time. Now, patients with this anatomy can certainly go ahead and carry a pregnancy. A pregnancy may occur in either half uterus, usually not in both at the same time. And the baby would grow within the uterus, the half uterus. There may be some concerns about early labor or early delivery, but that's something that we could probably talk a little bit more about as we get some further questions.
Thank you. The next question states that her daughter was born with a bacterial association, perineal fistula, and anal atresia, both repaired, and she wants to know more about a vaginal birth versus C-section.
Wow, we're already getting into the very interesting questions right from the start. So in patients with anorectal malformations, and it's very important to think about not only when they're children and have their reconstruction and think about things like constipation and bowel control, but it's also important to think about future, including sexual function, as well as becoming pregnant and having babies. The area in which the surgery occurs, I'll again turn to one of my diagrams. Let's go back and show you the area in which the surgery occurs. So if we turn to the drawing, here is the area of the vagina, and here is the area of the anus. In girls with anorectal malformations, what's very important to assess as an adult is how well healed is this area here. This area is called the perineal body. This is the area that's strong tissue that separates the rectal area and anus from the vagina. And as you know, when a baby is delivered through the vagina, this area can be stretched. And it's important then to assess the area before delivery. So we would recommend that patients would go to their obstetrician gynecologist, describing their previous surgery, have this area assessed on examination, and then make a decision about how it's safe for her to have her babies. We have had patients who have considered having vaginal deliveries in the past. It's something that has to be individualized for each patient.
You kind of touched on this, but the next participant asks about sexual function.
Wow, sexual function is a huge topic. I think that one of the things that we need to think about when we talk about sexual function is sort of the normal population, patients who haven't had surgeries or weren't born with an anorectal malformation. It's an area that can be a little touchy for everybody. So it's something that we hope that all patients will have a satisfying sexual life. But I do think it's one of those areas that we talk a little bit more about with our patients so they can feel more comfortable when they talk with their partner. For instance, some of our patients may have vaginal reconstruction, and that may be a little scary for them about how that may be for sexual intimacy. Almost all patients with anorectal malformations will have a very well-formed clitoris. The clitoris is an area that responds to stimulation and is the area that's responsible for most sexual satisfaction and orgasm. And reassuringly, that's very normal in most patients with an anorectal malformation. So I think if I were to just answer broadly, I expect that most girls and young women with anorectal malformations will have a healthy, satisfying sexual life.
And that's what most of our patients report to us. The next caller, or writer-inner, wants to know about the specific risks during pregnancy.
Another great question. Debbie and I have been talking much more commonly in more recent years with young adults who are born with anorectal malformations. Actually, here at Cincinnati Children's, we've been doing a long-term outcome survey, and we've been learning a lot about patients about their attempts to become pregnant, how that's worked out for them, possible miscarriages, how long they may have carried their pregnancy. So we're trying to get more and more information. It's an area that doesn't have a lot of data available presently. But what we have learned is that most of our patients have done fairly well with their pregnancies. They have delivered a little bit earlier than other patients in general. But again, remember the drawings I showed earlier. It depends a bit about an individual's uterine anatomy. With a half uterus, it's much more likely that someone would deliver earlier. However, in many of the patients that we've taken care of, Debbie, most of them have delivered not super early. Right. They've delivered probably in the late 30s or mid-30s for gestational age. A pregnancy lasts usually for 40 weeks. So someone may deliver maybe 32, 33 weeks in many of the patients that we have interacted with. The other thing to think about with a half uterus is thinking about perhaps a baby might not have the space and might present in a breech presentation, or instead of being head first, might come bum first, and that might suggest or necessitate the need for doing a cesarean section. Lastly, we talk about how the placenta might be positioned within the uterus. I don't know, some patients may or may not have heard of something called placenta previa, maybe a little bit higher risk. And then lastly, I think the most important thing to talk about for any patients who are considering pregnancy is overall health to begin with. It's very important for any woman who's thinking about becoming pregnant to see her doctor and think about if she has any long-term conditions. Many of our patients may struggle with, let's say, kidney issues, and it's very important to determine if their kidney is healthy enough to withstand pregnancy, because pregnancy is a stress on the body, including on the kidneys.
The next person wants to know about the effects of a tethered cord, which is now untethered, on sensation.
That's a very interesting question as well. Again, an area that doesn't have as much data as we would like. We do have many patients with tethered cord that is detethered when they're young, and their function sexually has been good from what we have seen. It is a little bit of an area that's a little bit of a challenge, as I sort of alluded to earlier. It's difficult for patients to kind of assess their feelings sexually. All you really know is your own experience. So it can be a little hard to say, is that normal, or am I feeling as much as I should be feeling? Our patients have been able to experience orgasm and to be able to have a healthy sexual life. An important consideration, which isn't exactly the question that was asked, but patients who have had a tethered cord, it's important for their doctor to be aware so that when they're thinking about having babies, the idea of having an epidural may not be an option for them if they have had tethered cord that's been repaired.
One of the participants' daughter has both bowel and some buccal tissue used to create a neovagina, and she's asking about specific concerns that her daughter will have in the future.
Again, awesome question. So I think one of the things we need to think about genital anatomy is that many patients may have required to have a graft or a tissue substitution to allow them to have an adequate vagina or an outflow tract, like we say, for menstrual periods. So if someone has a graft or a tissue substitution like bowel or a buccal graft, we don't usually consider a vaginal delivery as an opportunity for them. It's something where they would need to have a cesarean section for delivering a baby. However, that tissue functions very well sexually. Some of those patients have required doing vaginal dilation, and that's something I know Debbie has worked very closely with our patients. I think she could probably provide us a little information about how doing vaginal dilation can be performed.
I think vaginal dilation is usually more needed immediately after surgery or shortly after surgery. And it's an uncomfortable thing to do, but most girls have to find a way to do it that's comfortable for them. Some of our patients have liked standing up in the shower and inserting the dilator in and out because they find it easier in the standing position to be able to reach the area. Some of the girls, on the other hand, like to do it laying on their back with a pillow behind them so they can have enough control. And one of our patients even liked to do it in the bathtub. She felt as if at the end of her bath to insert the dilator in and out was easier for her because the tissue was a little bit more pliable and soft after being in the bath water.
And I do think another addition is that when we do vaginal reconstruction, even on girls that may be young, even as young as 1 or 2 years of age, we typically do not expect that there would be the need for any vaginal dilation early on. That's something that is introduced when it is time to consider using the vagina for sexual purposes. That's a time when we introduce that sort of topic and the need for that. Should we keep going?
We should keep going. This is kind of on a related matter. This participant's daughter has a vagina created with bowel tissue and has had a lot of mucus discharge. And she wants to know, she's concerned about perforation due to the inflammation and developing ulcerative colitis.
So we have had a fair number of patients who have required, as we said, a substitution of tissue in order for the vagina to reach the skin of the perineum, so a graft of tissue. Bowel grafts are something that we have a fair amount of experience with. We actually did a review here a few years ago of our patients who had had a bowel neovagina. We found that patients who have a part of the rectum substituted as the vagina tend to have more mucus than other patients. And Debbie and I have worked to sort of coach patients on how we can decrease the amount of mucus. That can sometimes be bothersome, right? Needing to wear a pad each day or considering the odor. So Debbie actually works with patients and families about ways to decrease that mucus.
It's really easy to do. You just take a catheter and some normal saline. A lot of our patients do intermittent cath through their urethra or their Mitrofanoff, so they have catheters at home. A lot of them do bowel flushes, so they have normal saline. I usually like to get a bulb syringe for our patients, because if you're trying to maneuver a syringe with your hand and hold the catheter in place in the vagina, it's a little bit hard. So if you have a bulb on the end, it's easier to manipulate. But just flushing out the area with some normal saline, and there's no real rules to this. It's kind of made up, as we say, and it's very individualized for every patient. But if you do it once a day for several days and just kind of see how the mucus discharge decreases, and then you can decrease the frequency of the irrigations. And girls will report that they can go sometimes for months with not having any discharge after that. Then they'll notice it's kind of start up again, so they'll get the catheter and the syringe out, do a couple of irrigations for a couple of days in a row, and then go for that period of time again until they notice it again.
The whole topic of bowel neovaginas has many sort of particular issues that relate to it. We talked a little bit about the mucus. I think we've had patients who may have experienced prolapse of a neovagina, and that may require a small surgical intervention to help with that. I think that patients and families have a lot of questions because this is tissue that wasn't natural vagina and is used as a substitute. And I think that we can say that the patients that we have cared for that have progressed into young adulthood have found that that vaginal substitution has done very well for them. That even though they have been a little hesitant about starting to use it, as I'm sure with many people are hesitant on starting to use the vagina, but everything went fine for them. There's sometimes a little bit more delicacy to that tissue. I think it's just not used to serving as the vagina, and there may be a little bit more bleeding with the beginning of having sex, but that gets better and better with each further experience.
I noticed as our patients were getting older and some of them were engaging in sexual activity that they were reporting the next morning, calling me up, that they had bleeding. And as we had more patients engaging in intercourse, I try now to be proactive, now that we've realized that the tissue is a little bit more friable, a little bit more delicate. Try to be a little bit more proactive so that there's not so much angst when that occurs. And it tends to decrease to the point where it isn't really an issue after a short period of time, like weeks actually, as short as a week.
I mean, even though we were just talking about how to decrease mucus, the right amount of mucus could be helpful. It can be very helpful lubrication with sexual intimacy. So at some points, the mucus can be helpful in certain regards.
Another participant wants to know about other causes of vaginal bleeding.
Oh, another good question. So in patients who have a substitution of tissue for the vagina, a bowel neovagina, one thing that we always talk to patients and families about is that with time, there's a very small risk of developing some abnormal cells within the vagina. And so one of the early signs of that can be some bleeding that you find from the vagina. Now, not to get too worried right away, there are a lot of things that can cause some bleeding from the vagina. One is periods, right? So if your daughter is 12 years old, shows some signs of puberty, then we would expect that that would be normal to have a period. So kind of keeping track of it and determining the pattern of the bleeding is important as well. Now sometimes if you've done a recent irrigation and you may have first time past the catheter, maybe there was a little trauma and a little bleeding from that might be expected. But I think if it's a persistent pattern of bleeding that can't be described, it would be important to be evaluated by your provider. We recommend that patients who have had a bowel neovagina have what we call surveillance vaginoscopies, or surveillance looks at the vagina intermittently as they get older to be sure that there's no concerns.
And I think a good opportunity for that is, as Dr. Breech was saying before, a lot of the girls have some urologic issues and they're followed regularly by the urologists who do surveillance cystoscopies periodically. And that's important when it's important for you to communicate with me, because if that is being scheduled, then we can coordinate Dr. Breech to be in the OR at the same time.
And I think that is, again, an advantage here at Cincinnati Children's. Working so closely together, We kind of build in some times when it's important to kind of touch base again with the gynecology service. Or for us, if we encountered a young woman who was thinking about having children, we would want to have the urologist and the nephrologist weigh in about how her kidneys and bladder doing before she starts thinking about that. So I think we kind of work well together as a team and decide sort of what will be best for the overall patient and kind of minimizing having to come back and forth or a number of different procedures. Great.
One of our participants says that she's 16 and has been always told that she had an abnormally small vagina, and she wants to know what kind of things could be done to correct this issue. I think we talked about dilating before, using a dilator, passing it, and using an increasingly larger size as you go on can kind of stretch that tissue. But sometimes that's not enough, and maybe you can speak to the other issues.
Right. Debbie is our expert on dilating. So let me just tell you, she's worked with many patients from many parts of the world on how to do effective dilating. So whenever I need a little advice, I just go to Debbie. But I do think that there are patients that perhaps the reconstruction that occurred when they were a little girl was okay for the flow of menstruation, but that maybe the vagina has scarred a little or might not be stretchy enough for the size needed to engage in sexual intimacy. We recommend having an evaluation before jumping into those adult activities to be sure that the vagina is stretchy and pliable enough so that you wouldn't have pain or trauma or a tear, something that could be very upsetting and scary. So having that evaluation, the doctor could do an exam, either using a dilator to calibrate to see the size, or an examination in the office can help us to know, is the vagina going to be stretchy enough? Now sometimes it's just, as you remember, Debbie, it's just the opening of the vagina. The inside of the vagina, the whole walkway, pliable, large, fabulous. It's just right where you step off the sidewalk onto your walkway. And if it's just the introitus or the opening, that can be a relatively small procedure called an introitoplasty. And often patients will go home on the same day. They may have to do some dilating a few weeks later to make sure it's nice and stretchy at that place. But it could be a small procedure like that. So again, some of it depends a little bit on your own anatomy, but there's some procedures that we could talk a little bit about that would help so that each person could feel comfortable with their particular situation.
Someone says that their daughter has several midline defects, and she's now 2, but has never been checked out gynecologically. So she's wondering what tests would be needed, what would be warranted, and what ages those would be done.
Okay. So a midline defect is a little bit more complex. Oftentimes we think of that as maybe girls who may have been born with almost an extrophy-like spectrum, where when the body was forming and things came together in the middle, they didn't quite meet all the way in the middle and things are separated. Often that means there's sort of duplication of structures. We often see in those girls, we would see sort of 2 hemiuteri, like we saw in the drawing earlier, but actually pretty widely spaced, one on one side of the pelvis and one on the other side of the pelvis. In addition, we may even see externally duplication, where there might be actually 2 hemiclitoris or 2 half clitorises that actually aren't all the way together. You may even see the labia separated. So often it's a little bit more complex, but it's something that easily by examination or things like ultrasounds, MRIs can be used to delineate anatomy. At our center, we recommend that girls undergo a more thorough evaluation early on. So when girls have their repair of their anorectal malformation, they meet Debbie and I even when the girls are little babies or girls who are like 2-3 years old, because we think it's important to figure out what's the reproductive anatomy for the future. So we'll run in there and do a vaginoscopy or ask for an ultrasound. It's hard between the ages of 1 year and about 10 years old to be able to really fully delineate the reproductive anatomy because there's no hormonal stimulation. And the hormonal stimulation is what really allows us to fully delineate the anatomy. And so at that point, we often ask for an ultrasound to be performed. In our team, we usually say, somewhere around a year or so after you see the breast development. Debbie and I say, as soon as they start needing a bra, start the countdown, and then we'll know when they need to have an ultrasound to be sure their anatomy is healthy and that we don't have to worry about menstrual flow. Because menstrual flow is an issue long before we worry about the sexual intimacy.
And I will throw something in here. Typically, girls with anorectal malformations have very well-formed ovaries. The ovaries come from a different embryologic source, so they're not usually involved in whatever it was that caused the anorectal malformation. But they tend to be a little bit higher. Mm-hmm. And I get a little sort of panicked phone calls from parents whose daughters had an ultrasound and telling me that the technician couldn't find the ovaries. They don't have ovaries. Well, they most often, almost 99
plus
% always have ovaries. They're just a little bit higher. So if you're with your daughter when she's having an ultrasound and you see the tech kind of scanning and kind of scanning and kind of scanning, you might want to say, her ovaries are probably a little bit higher. If you just go up a little bit higher, you'll see them on the scan and everything's fine.
And that's a really good point. I am so lucky working here at Children's to have Debbie. I think that it's really important to sort of develop an ongoing relationship with a team that you can sort of ask these questions ongoing. We're lucky to have the opportunity to share our knowledge with you today, but these are questions that come up like 10, 12 years after your daughter had her surgery. So we kind of like to provide kind of a roadmap for what to expect and what to worry about or what not to worry about. What is going to be just like every other 12, 13, and unfortunately 14-year-old girl. But great. We're having a great time and we hope you're getting the information you need as well.
Well, this is a little bit off topic, but not too far off. Someone whose daughter has cloacal exstrophy is wondering if there are some predictors of continence that she can kind of look towards.
Yeah, I think cloacal exstrophy is certainly one of the more complex of all the anorectal malformations. And we have been fortunate to see girls as young as newborns to girls who are in their mid-20s, I would say, are our older patients. Yeah. Unfortunately, being the gynecology team, I'm not sure that we can give you a lot of information about predictors of urinary continence or fecal continence. We can tell you much about reproductive potential. Patients with cloacal exstrophy actually usually have two hemiuteri, again, widely spaced, sort of on two separate sides of the street, so to speak. And often those will function so that those need to have an outflow tract or a way for the menstruation to be able to come out when stimulated. So that's been a very important part of our role here at Children's, that even when little girls are getting their very first colostomy, it's very important for us to be there to make sure that there is a uterus, how well developed it is, and then making sure that there's a tract for outflow. If there isn't a well-developed vagina, then we actually kind of put that on hold, but know that when any other reconstruction occurs, it's something that we can partner with other surgeries. And that can be with a pull-through if that happens. Sometimes it's with urinary reconstruction, but it's something that we kind of put on our list and know needs to be done before the evil menstruation.
Several people are asking about prolapse. One person says that her daughter's prolapsed twice, and she's wondering if that's going to be an ongoing problem. And another participant said her daughter's also prolapsed twice. And she's wondering if it has anything to do with her bowel regimen and if there's any changes that are going to occur with sexual activity.
Wow. Okay.
Lots there for you.
Yeah, we can chew on that for quite a while. So I think I mentioned prolapse, and of course I was sort of thinking about vaginal prolapse because especially in patients who may have had a graft or a tissue substitution at the vagina, they're at a little bit higher risk of vaginal prolapse than patients who have natural vagina. And so I was thinking of vaginal prolapse. In addition, girls who might have a more complex anomaly like, let's say, cloaca or a very high cloaca or a long common channel, sometimes their musculature at their pelvis is not as strong and as well developed, and that in and of itself can put them at risk for prolapse either of the vagina or of the rectum. So sometimes we just need to realize that it might be related to the overall condition or the complexity of the cloaca, and not so much due to the tissue substitution or the technique with the surgery. So when you ask a little bit about will the bowel management or sexual activity affect the prolapse, I think that it could. If, let's say, your daughter is constipated for a while, there's a little bit of pressure with the stool in the bowel, and that could cause things to pooch or to stick out a little bit more than you might see if she's not carrying a lot of stool. So maybe some adjustments could help the prolapse some. It would be unlikely that things would completely disappear with just some changes in an enema regimen. Now, as far as sexual activity, that could certainly affect probably vaginal prolapse a little bit more. It's another question we can add to our long-term outcomes list when we're asking our patients about from a rectal prolapse standpoint. But from a vaginal prolapse standpoint, it certainly would allow some redundancy and not have to worry about is the vagina too small, per se, in most patients. I hope we've answered those prolapse questions. We can always come back to it if you think we didn't get to it.
There's also a lot of questions about puberty and pubertal development, how parents can know if their daughter is going to go through normal puberty, and when they should be evaluated. Do they need to return to Cincinnati to see us? Can they be followed at home? What should they ask their physicians at home to look for?
These are also good questions. My daughter is now 14, so I can completely understand any terror that you might have about puberty, because now I have lived through it and I'm starting to learn a little bit more and to calm down a little bit about puberty.
And I have survived it, so.
Luckily, I have Debbie at all times. I have her cell phone, just quick dial right on my phone. But yes, I think that puberty is a time that we start thinking about changing the way we think about our daughters. Instead of little girls, we're starting to think of them as young ladies and young women, and we worry a little bit like any other good mom is going to do. The first sign, of course, are the breast buds, which shocks mom to see them as early as like 9 years old. And that's okay. That's actually normal nowadays. The normal age of getting periods is somewhere around 12-ish, a little bit over 12, 12.2 usually. So we really say when you start seeing breast development, you should expect to see the periods somewhere around 1.5 to 3 years after you see the breast buds, not when they're ready for the bra, but the actual bud. So it's really important to kind of think about that time frame. And once that gets started, we really want to be reassured that the menstruation can occur without any issues. It may have been fully evaluated when she was a little girl, obviously on her initial surgery. If not, it's a time we can start using things like ultrasounds, and that's our typical recommendation, is somewhere around 9 months to a year after she needs a bra. Let's get that first ultrasound. It can tell us a little bit more about the sort of floor plan of the house of the uterus. Because with puberty, the estrogen will stimulate the wallpaper inside the house, which can let us see the floor plan a little bit better. So, short-term recommendation would be, once you see the breast buds going, about 9 months to a year, first ultrasound.
And that's something else that we can coordinate with other things that you have going on. A lot of the girls who have surveillance renal ultrasounds, we can just, since the timing of this pelvic ultrasound is not real specific, we have a big window to work with there. You can wait until your daughter's next scheduled renal ultrasound and then ask the doctor or ask us to order the pelvic ultrasound along, and you can have both of those done at the same time.
Yeah, it can be helpful because we know going back and forth to the hospital multiple times, getting multiple studies is not fun, and especially bad for missing school. Right. So we try to correlate it with other activities as well.
Here's another question about periods. The family would like to know, with a bicornuate uterus, do they have 2 periods a month?
Which I love this question. It's one of my favorites, so I'm finally glad that someone asked it. And it allows me to use my diagram again, which again is great fun for me. So we're going to go to the diagram. So girls with cloaca with 2 uterus will have what I call diagram number 1. right here, which has 2 half uteruses that you see on each side. Each has their own front door or cervix. And then we said that most of the time that these vaginas would be unified into one by the time she's old enough to be having periods. So what happens is that the lining is stimulated each month on both sides, and it's equally stimulated because the ovaries, which I will draw in, stimulate that lining. And then the brain triggers for usually only one egg to be released. That egg, if not fertilized, will come down, will not need to have an implantation, and then will trigger both periods to occur at the same time. So thankfully, moms, dads, aunts, friends that are now on this live event, thankfully it won't be 2 periods per month. It will be 1 period at a time. Now, 1 period total. The only thing to think about though is that maybe this side might start flowing on, let's say, Sunday, and this side doesn't start flowing, let's say, till Monday. So this side goes from Sunday to Friday. This side goes from Monday to Saturday. So maybe Sunday to Saturday, maybe it means the period lasts a day or so longer than for patients who have 1 whole uterus.
And what about tampon use for girls that have a neovagina?
Debbie, she's always got another question. That's the reason I'm working with Debbie. She always has another question. If the vagina is unified, so I'm going to clear this image off. So we're going to go to a different image. Okay. So if I were to draw, because I can't resist the opportunity to draw my own uterus now. So if you have a single uterus or even a double uterus, when the vagina is unified, even if you have a segment of a neovagina, it's possible to try to use a tampon within the vagina. Usually the tampon will be able to be inserted most of the way into the vagina, and usually it's possible to try with a neovagina. I think we mentioned earlier that sometimes the muscles of the skin and at the opening to the vagina might not be as strong in patients with more complex anomalies. And so sometimes the muscle just isn't strong enough to hold the tampon there long enough to be comfortable. So it's possible, but it's something, again, I'd probably recommend interacting with either with us if you see us or with the gynecologic provider nearby at home. That's one thing that Debbie is phenomenal about doing, is she helps me a lot with interacting both with patients and families, but also local providers, because I'm sure many of you have had the experience of going into the doctor and you're explaining more about your daughter's condition than they seem to know. And that's a little unsettling. So we can serve as helpers in that way.
Right.
I think we're done with this image now.
The next question is about options for tissue to use to create a neovagina.
So there are multiple tissues to use to create a neovagina. I think part of that decision-making process occurs when the vagina is reconstructed. So in girls and young women with anorectal malformations, we often advocate for delineating that anatomy at the initial surgery. So often the rectum could be placed too close to the vagina or be in the place where the vagina is supposed to be. So as the surgical team moves the rectum into its proper position, kind of leaves this big space, and it seems like the proper time to go ahead and do that vaginal reconstruction. Problem being is what tissue to use. So at that time, with moving the rectum and colon out of the way, often the colon or rectum are sort of first choices to use for reconstruction of the vagina. In our center, there's some kind of rules of engagement on what can be used for the vagina. The rectum is off limits in many circumstances because the rectum is very important to use as a reservoir for good bowel control. So in order to get a great vagina, we don't want to compromise any good bowel control. So sometimes that's not an option. So colon is an option, which is just a little bit higher up than the rectum itself. Buccal mucosa, or the inside of the cheek, buccal meaning the name of that, is also tissue that we've been using in older patients. When we do a buccal graft or a segment of cheek to use to create the neovagina, it requires wearing a mold within the vagina continuously without moving around for about a week. I'm sure that those of you who have kids who are 2 years old cannot imagine your little 2-year-old lying with a mold in the vagina, pretty much still in the hospital bed for a week. It's not happening. So we have reserved that for a little bit older patients. So at this time, I would say for girls with anorectal malformations, if the neovaginal reconstruction is performed as a small child, it will most likely be a bowel neovagina. And there are different segments of bowel. We mentioned rectum. There's left colon, sigmoid colon, and then there's also small bowel, which we have used as well. Most of those require surgery in the abdomen to get that tissue, as opposed to doing it from below.
There's several questions specifically about perineal fistulas. One about the incidence of associated gynecologic anomalies, and then another question about a young child whose diagnosis was missed at birth. And so now that she's a little bit older, specifically in this question, 8 months, they're wondering about the ideal time for surgery, what are the considerations for surgery, what are the risks, the benefits, and the implications for sexual and reproductive function.
Wow, that would be
a mouthful.
Yeah, it's a mouthful from Debbie, but I'm sure stressful for mom and family to be thinking about 8 months old and now getting a diagnosis, and so that probably would be a little stressful. But I think that what I would approach this initially by saying that girls with something called a perineal fistula. So perineal fistula is when the rectum kind of comes out on the skin, a little bit too close to the vagina, but on that perineal body, that area that I was showing you on the diagram earlier. And unfortunately, then the rectum is not included within the actual muscles or the sphincter. And so that doesn't work as well for good bowel control if the rectum isn't coming right through the muscles. So that can be an issue. Now, we have found that in girls with rectoperineal fistula, they seem to have the least highest incidence of having associated reproductive anomalies. So we found that only about 1 to 3% of those girls will have uterovaginal anomalies. Now, if you think about rectovestibular fistula, where the rectum is much closer to the vagina, in the vestibule or the hallway leading up to the vagina, those patients have 7 to 10% association of uterovaginal anomalies. About 7% of patients will have a septum or divider down the walkway, and about 10% of the patients in our population had an absent vagina completely. And in patients with an absent vagina, the majority of those, about 70 to 80%, will have an underdeveloped uterus as well. Now, in girls with cloaca, the more complex anorectal malformation, we have found that about 59 to 60% of those girls will have duplication of the uterus or vagina. So I think if your daughter has a rectoperineal fistula, she has the lowest chance of having an associated uterovaginal anomaly. So that's the first part of the question. Second part was missing the diagnosis and finding it later. I think that many girls with rectoperineal fistula will have constipation as well. So even though the rectum is not within the muscle, they're constipated, and so they stay clean and dry. So we have even met young women who are even in college who never had surgery, who were able to remain clean and dry throughout high school and into college. So sometimes, depending on sort of the position of the fistula, the size of the fistula, and your ability to be clean and dry, would dictate sort of when and if you need to do something about it. If a patient didn't have surgery, we would not recommend having a vaginal delivery because it would be too much risk that by stretching the vaginal area, it would stretch so much that it would tear into the skin and possibly into the rectal area. But we have found, Debbie, right, that the patients maybe had some improvement in their quality of life when they were older if they addressed this concern.
Especially girls that are really active in sports have a little bit of issue with continence without being repaired.
Mm-hmm.
One of the next participants would like to know about the effect of pregnancy on continence.
Wow, these are great questions. So this is a question that we had as well. I think that what we have been looking at is the sort of long-term outcomes that patients and families have been willing to share with us. Unfortunately, many of the pediatric surgeons aren't following the patients when they're old enough to be becoming pregnant, having babies, and so perhaps they're not as familiar with those long-term outcomes. So we've been contacting our patients and asking them to complete a survey, and so getting much more information, asking very specific questions about laxative use, enema use, continence pre and post delivery. So we're starting to get that information. So if you had been a patient of the center, it would be great if you do receive a survey, if you consider answering it. Or if you have not been a patient but would like to share information with us, we're always receptive for that. What we have been learning, however, is that most obstetricians opt for a C-section. So even though it may not be needed, they may feel more comfortable offering a C-section just to protect your daughter from the possibility of a tear into the rectum. So the vast majority of patients who have responded to us have shared with us that they have had a C-section. So that would decrease the risk of changes in continence. Now, Debbie and I have talked to several of our young adult patients who have struggled with increasing constipation with their pregnancy.
Do you want to comment on laxatives and constipation in pregnancy?
Very good. We experienced some of our patients, maybe their obstetrician said they should stop their laxatives. I was like, no, don't stop the laxatives. That's like the last thing on earth you want to do. Pregnancy is associated with constipation itself. And we know that patients with anorectal malformations already struggle with constipation. So patients can become impacted during pregnancy, very uncomfortable, and be left in a very difficult situation. So continuing laxatives is safe with pregnancy. It just is something that you need to talk with your doctor about and have them understand the importance for that. Even in patients who might be doing enemas, they're safe to do with pregnancy. It's just something that we may have to adjust, perhaps the frequency, the amount, because the bowel slows down so much with pregnancy.
Looks like we have a lot of questions about periods, and I know I get a lot of phone calls. People are calling because their daughter's starting their periods and their periods irregular, or they seem to be having a lot of cramps or issues like that, and they want to know if that's related to the condition or most often.
See, Debbie can even answer this one. She can like rattle this off easily. Because I think it means that your daughter is
normal.
Exactly. When periods start, I usually use the example of it's kind of like learning anything else, like learning to ride a bike or I learned first what your daughter's favorite sport is, and then I use that as the example. But you don't become an expert at this sport right away. It takes some practice. And so what happens is the brain is triggering the ovaries, which is then triggering the uterus, which is then triggering the period to come out the door and down the walkway. So you can imagine there's all kinds of opportunity for misfires along there. And that happens in the first year to a couple years after getting the periods. But there are some rules. If the periods are too close together and too heavy, that can put her at risk for something we call anemia or low blood counts, making her dizzy, lightheaded, tired. Kind of hard in a teenager to tell, tired or not tired, right? They sleep all the time. But looking out for those kinds of things. So we have in our team a little rule, the 1, 10, and 20 rule, then I added the 2-month part on. The 1 is that you can't, if your daughter soaks a pad every 1 hour, that's worrisome for too much bleeding right away. 10, if she bleeds for 10 days or more, that's bleeding for too long. And 20 is there's less than 20 days between the start of one period to the start of the next period. So newsflash, your daughters have to keep track of their periods, which seems to be like a new innovation for them. However, you can go at them with their devices and tell them there are really cool apps that they can use to keep track of their period right there on their phone, which never leaves their side, right? The phone is always there. So it should be easy to keep track of the periods. If those rules are being broken, it's probably important to see the local provider, and it may be just something that's learning how to have periods and not really related to their anorectal malformation.
When would you recommend that a young girl see a gynecologist if they haven't been regularly seeing one?
So because I'm an obstetrician gynecologist by training and focus on pediatric and adolescent population, I might be a little more generous with who needs to see the gynecologist, right? But the American College of Obstetricians Gynecologists recommends that most girls see a gynecologist around the ages of 13 to 15. Not because they're going to have any scary kind of exam or anything like that, but more to make sure that their periods are kind of going the way they should be, that they're not at risk for anemia, that they're not having too much pain with periods, keeping them home from school, and also reassuring them what to expect. So it's not unusual for me to see a girl maybe in their early teens and just learning about their periods and helping them with things that might be influencing their participation in sports or activities or their studies. So I think that's the sort of age we would recommend. In girls with anorectal malformations, we have that roadmap, and the roadmap recommends to start with that ultrasound, remember, a year or so after the start of development, so that we can see what's happening at the uterus and be sure that things are going okay. Now, if that's all been fully evaluated when she's young, maybe we can relax a little on those evaluations.
There's also a couple of questions about menopause and how anorectal malformations may or may not affect menopause.
Which is a really cool question, because now I have been able to meet adults who are like actually older than I am, if you can imagine that, who are born with anorectal malformations, who've come to Cincinnati Children's to be seen. So it's been so cool to get to meet them and understand maybe how their condition has impacted their life. What I've learned from them, and again, it's a small set of data, is that their menopause seemed to be on time with other patients. The ovaries didn't seem to fail earlier in patients with anorectal malformations, any earlier than the rest of the population. Now, one thing Debbie and I talked to patients about is perhaps if the patient had more intra-abdominal surgery or required much more reconstruction, could there have been issues with maybe some of the blood supply coming to the ovaries, and maybe if that was affected with the surgery. So actually nowadays there's a blood test that we can do to look at what we call ovarian reserve or ovarian potential, or the ability of the ovary to get eggs ready. And that blood test is valid at any age. So it can be done in a young woman who's preparing to maybe think about having a family, to let us know and reassure us that her ovaries are ready to go.
There's also a couple of questions about fallopian tubes and the fact that they may have been reportedly scarred in their daughter or had to be removed with a specific surgery.
So Debbie and I are sitting kind of close for this live event tonight, so I can't do my usual activity, which is for me to pretend that my body is the uterus and that my arms are the fallopian tube, and anyone who meets me here at Cincinnati Children's knows I'm very dynamic, and it's very hard for me to even hold my hands here right now. But we use those analogies a lot and those demonstrations to help patients and families understand it's important for the fallopian tube to be able to move the egg from the ovary when it's released down the tube to the uterus so it can be fertilized. So it's important for that tubal motility. So if, let's say, a fallopian tube is scarred, maybe even scarred closed, or accumulates fluid for many years, that can affect its motility in the future when we worry about childbearing. So if we were to identify tubal problems early, we can sometimes use medicines to kind of suppress the fluid that might accumulate in the tube and sort of protect it until we're ready to think about using the tube. There are some x-rays that can show us if a tube is open. However, that's something that requires like a pelvic type of exam. And so it's usually reserved for when girls are young adults and thinking about when they're ready to have children. So we use that x-ray at that time to make sure that the tube is open. I think that's everything about fallopian tubes. As much as I want to do my demonstration, I don't think I'm going to be able to have enough room to do it. I don't want to knock Debbie out for the end of the event.
Which actually brings us probably to our last question. The time's gone pretty fast. This participant says that her daughter, she noticed, has started to have labial adhesions. She's wondering if it has any connection to the anorectal malformation. And aside from that, her pediatrician doesn't really want to do anything about it right now, and reassured her that at puberty it shouldn't be an issue anymore, and she's wanting some reassurance about that.
Well, that's a question that comes up many times in our gynecologic practice. So even outside the realm of anorectal malformations, I know Debbie has become an expert on the management of labial adhesions and working in our practice. I think it's actually changed over the years as well. So first reassurance is there's no association of labial adhesions with anorectal malformations. So there's no increase with patients or girls with anorectal malformations. It's thought that maybe girls who develop labial adhesions maybe have an increase in their inflammatory response at their labia or at their bottom. And so even minor irritations might cause a little bit more inflammation for those girls than others. And with that increased inflammation, it causes the labia or the lips to stick together, thereby almost not even being able to see the urethra or vagina themselves because the labia stick together so tightly. So moms will come in and say, I can't even figure out where she's peeing from. I can't even find an opening down there. So when we take a look and we gently lift the labia, often we can find a tiny little opening where the urine is coming from. And so as long as a girl is urinating okay, we don't always have to treat the labial adhesions, because when the estrogen levels go up, then those will actually get a little bit better because it helps calm the inflammation a little bit. Typically, many gynecologists are using an anti-inflammatory to treat that now. A medicine called betamethasone is the typical medication utilized. This is a topical ointment that's applied nightly to the area, and usually we apply it nightly and then it takes about a month to 2 months to see that opening nicely so then the urine can flow freely. And again, at puberty, it's expected that it will get a little bit better and usually actually resolve for most patients. There have only been a few that needed any more treatment at that time. Now, I'm hoping we can do one more question.
I think you should use the last, 4 minutes here to talk about the uterine transplants that have been in the news lately.
I'm glad you brought it up, because I'm sure that moms are thinking about it all across the United States and across the world. It's very exciting news. Uterine transplants have been something that has been undergoing research for several years now. Actually, there are several areas in the US as well as in Europe that have been researching the role of uterine transplantation. What one would expect is to transplant a uterus from another woman into a patient who was born without a uterus. The patients who have been reported to date were born without a uterus. It's not that the uterus was removed for other indications, they were born without a uterus. The patients that have been studied to date, that was the only thing they were born with. So they were only born with uterovaginal agenesis, not with cloaca or other anorectal malformations. So we're still learning what might be the role for uterine transplantation in patients specifically with anorectal malformations. However, it has been successful in a small number of patients on a research standpoint only. There have been the patient that you recently heard about who carried the first pregnancy to viability and delivered her baby by C-section. But during pregnancy, she required using medications that suppressed her immune system. So the same type of medications you need for liver transplants, kidney transplants. So it's a very serious thing to transplant a uterus, but gives us a lot of hope for what might be for many girls and young women for the future. So hopefully this will be something that will be an option in the future.
And on that note, I think we're going to have to say goodbye. Thank you so much for everyone for joining us this evening. The session's going to be emailed. I think the link to the session is going to be emailed to all the registered participants later this week. And you can watch us over again.
Yeah.
And thank you to all the people who wrote on our blog and follow us on our what do you call it? Facebook page,
all that social media. But I wanted to thank Debbie for joining me tonight, and thank you all for all those fabulous questions. Hopefully we can do another session again in the future. We hope that you were able to get the answers to your questions and enjoy the event. Thank you.